So I've been asked to give you a quick 10 minutes about surgery for osteosarcoma. So I appreciate not everyone in the room knows what we do in terms of surgery. So there's a little bit of background and just to float a few ideas about the sort of things that we're interested in as surgeons when we're talking about research projects. So of course it takes a big, good-looking team to look after patients with osteosarcoma. And so just to point out, the surgeons are in this team. You hear a lot about chemotherapy drugs, and of course they're important, but surgery has a very important role to play here. So essentially, if you're going to cure somebody of an osteosarcoma, you have to take the tumours out, and that's fairly well established. So surgery is important for cure, and in the guidelines it says the aim of surgery is complete removal of the tumour. And so to do that, we want to make sure that it has negative margins. In other words, the tumour comes out covered in normal tissue. And we want to estimate whether or not that's been a good enough operation based on how well the tumours responded to chemotherapy and what the margins actually are. But this is, generally speaking, complex surgery. It carries with it big risks, and it's usually life-changing, the sort of surgery that we do. This gives you an example of some of the kind of people that we see, or some of the tumours that we see. So here's an osteosarcoma in the distal femur. Here's another one in the distal femur. Here's a large one of the proximal humerus. Here's one in the mid-shaft of the tibia. And we do a range of procedures. We can replace major long bones with endoprostheses. That would be our standard operation. We can use things like surgical navigation to do very complex osteotomies, to take out tumours in a geometric kind of fashion and reconstruct them whilst preserving, for example, the hip in this case. We've also got access to quite new and interesting technology. This is a customized implant for this patient, which is put in using a special jig that cuts exactly the right hole in the pelvis into which we put a custom jig. And sometimes we do amputations. So these are the sort of things that we do in surgery. So if you're going to take a tumour out properly, you need to know where it is. And so good imaging is really important. And we'll talk about advances in imaging today and whether that can help us take all the tumour out. We need to know where the tumour is anatomically, whether it's responded to chemotherapy, because that might also just determine what kind of surgery we offer. And we know that we don't always get it right. We have a positive margin rate about 16% of the time. So could we do better? Yes, we probably could, and that's quite an interesting research question. The question we alluded to in the ICONIC study is whether or not a tumour is operable. And what does that really mean? Well, that usually means that we think the operation is of such magnitude that it's not appropriate to do it. It doesn't mean that you couldn't do it. But clearly there's quite a complex decision to be made here, and it probably varies from centre to centre and from patient to patient. Could we get better at looking at the margins in theatre? So could we do imaging during the procedure in order to see what the margins are? And we're going to hear a bit about that later. Could we use better navigation techniques, so better than just the surgeon's eye and the surgeon's hand in reference to the scans? Can we use machines or robots to help us make more accurate resections? And of course, after we've taken the tumour out, how good was the resection? So what's our best system for assessing the margins? And there is, for example, from the Birmingham Centre that Lee's done a project looking at a new classification of osteosarcoma margins, which is clinically useful, and that's the sort of thing we'd want to look at in a bigger study. How do we reconstruct? So reconstruction is a balance of risks and benefits. So for example, should we do amputation or limb salvage or rotation plasty you've heard about? Should we use a piece of metal or a biologic reconstruction? These reconstructions have different functional implications and different other outcomes, different risk profiles, for example. So if you have an amputation, your risk of local recurrence is very low. But if you have a limb reconstructed, then you run the risk of infection, loosening, failure of the reconstruction. And of course, we should be making decisions that are informed not only by what is possible, but also by what the patient's preferences are for their future. Our surgery is life-changing, so life after treatment is very important. These are the sort of domains of cancer survivorship that our patients experience. So they experience fatigue. There's a major impact on physical functioning with what we do. You can imagine if we've replaced a large bit of the femur, then your ability to get around is going to change. And there's all these other domains that impact in the longer term following the treatment we do. So the kind of questions we want to ask is, how can you best return someone to normal life? How do you follow someone up for relapse? And how do you measure how they're doing afterwards? So the physical domain is the biggest thing in survivorship for our patients. When we did a systematic review, we found 12 studies that reported poorer physical functioning in extremity sarcoma survivors generally. That's to be expected. That's poorer than if you are chronically ill or obese. Your level of physical functioning varies with time. It improves for up to 2 years. But your quality of life after about 8 years does come back to the same as it does for your peers. So how do you measure physical functioning? Well, here's a study that we've done. Gerrand did in Newcastle, where we used accelerometers, put them on patients. And you get a load of data out of these, but it's a way in which we can measure some of what the survivorship experience is. We can look at balance outcomes, we can look at how people walk. And then this study funded by Children with Cancer and Sarcoma UK, this is just one of many outcomes we got. This is what happens when you stand. If you've had limb salvage surgery, this is how much you wobble when you're standing. If you've had an amputation, you wobble a lot more. And these are the kind of data that we can get out as part of clinical studies to see what the impact of our surgery is. Psychological outcomes are very important for our patients too. So there's at least a question, not really a surgical one perhaps, but a question about how we best provide services for people. And we've heard already what a traumatic experience this can be for everybody. Social functioning is very good, very important. How do we get people back to normal living? What's the best kind of service we could provide for these patients? So in surgical follow-up clinics, we'll traditionally look at a patient, see how the reconstruction's doing, but perhaps we can do that with a bit of a broader perspective and ask people about pain, how they're doing in rehabilitation terms, limb fitting, return to work. Physical fitness is a particular problem for our patients, and we know from other cancers, breast and colon cancer and so on, that actually how your cardiovascular fitness is a big determinant of how well you do in terms of your cancer relapse. But we need to be designing services for surgical follow-up and general follow-up, which allows stratified and individualized follow-up services with a kind of more holistic perspective than we do at the moment. When it comes to surgical research, there are challenges. I've showed you the varied presentations. Surgeons have different approaches. There's perhaps a lack of standardization in what we do. We come up with personalized, you've heard about personalized medicine, that's something that surgeons have done for a long time, personalized surgical solutions. When it comes to publishing surgical research, surgical journals tend to be lower impact, and again, it's difficult to get funding for surgical studies. But there are some opportunities. So there are opportunities, just to go over these again, opportunities in imaging, so preoperative, intraoperative and postoperative imaging. How do we best look at the local anatomy? How do we do better surgery, make better decisions, margins, infection and so on? How do we improve survivorship? Biomarkers, you'll hear a lot about these going forward today. They're very important to allow us to measure the response to treatment and to follow patients up. And the fact that we're taking out a tumour does open an opportunity for surgical window studies. So there are questions about what can we do to the tumour before we take it out that might be reflected in the tumour once we've taken it out, and that will tell us something about the biology of the tumours. So I'm going to leave it there just to fly the flag for surgical research.